We begin case number 8 for today, describing a 13-year-old West African female who was brought in by her dad on account of developing several erythematous and pebbly swellings involving her gums, both upper and lower. The swellings were initially noticed some 15 months back, and despite being asymptomatic, they were of aesthetic concern and have greatly affected her socially, particularly at school. She is a 7th grader and has been doing well in school otherwise, in terms of academics. She found out that in recent months, she wakes up in the morning with pools of bright red blood in her mouth, and previous periodontal prophylaxis only mildly improved this bleeding. She otherwise has no other complaints and is in a state of good health. No history of fever, weight loss, shortness of breath, or intake of any medications. Extraoral exam was essentially normal, with no findings of lymphadenopathy. Intraorally, however, we find that the gingival swellings were soft and friable, with areas that were particularly bright red. Both maxillary and mandibular anterior gingivae were affected, and overall, the lesions were non-tender but bled easily on palpation. The interdental, marginal, and portions of the attached gingival tissues were involved bacolingually, and the surface texture was granular. No other pathology was present in the mouth, and the rest of the clinical soft tissue exam was effectively normal. The teeth were not mobile, but a little bit of crowding was observed in the lower incisor region. The patient's oral hygiene was quite reasonable. Panoramic radiograph did not show any hard tissue abnormalities. A full blood count and peripheral blood smear were conducted, but both were normal, with no evidence of atypical white blood cells. This was done to rule out a more common and sinister cause of gingival enlargement in this age group of patients, an acute myeloid leukemia. A gingival biopsy was then performed, and the histopathology revealed a mild papillary proliferation of non-keratinized stratified squamous epithelium with elongation of the retipex. This hyperplastic epithelium was spongiotic with a considerable amount of intercellular edema between the keratinocytes. This marked spongiosis was accompanied by neutrophilic exocytosis and vascular congestion in the subjacent lamina propria. Importantly, no epithelial dysplasia was observed, and certainly no leukemic infiltrates were seen. Combining all the evidence thereof, a diagnosis of spongiotic gingival hyperplasia was made. To be more specific, the multifocal synchronous variant, which is a rarer form than the focal variant. This type of gingival hyperplasia, which I will refer to as SGH from now on, is a benign disorder that is thought at this current time to be an exteriorization process or ectopic relocation of the junctional epithelium, since both of them exhibit similar immunohistochemical staining properties, strong full thickness immunopositivity for cytokeratin 19. The exteriorized junctional epithelium, which is probably caused by some form of minor intraoral trauma, is much more susceptible to irritational injury than a typical mature oral epithelium and responds reactively by undergoing inflammatory hyperplastic changes reminiscent of exuberant granulation tissue. As a result, it is highly likely for focal variants of this lesion to be misdiagnosed clinically and histopathologically as pyogenic granuloma or lobular capillary hemangioma. In the past, most cases of SGH were diagnosed in children and so was thought to be solely a pediatric disease. However, we now know that it occurs in a wide variety of age groups and also occurs in both genders, albeit commoner in females. This brings to light the possibility of a hormonal effect. However, at this time, the lesion is thought to have no influence from sex hormones. HPV, the human papillomavirus, is not known to play a role in the pathogenesis either, since indeed the lesional histology does not exhibit a virus cytopathic effect. Special HPV immunostaining techniques also rule out this possibility. SGH is a diagnosis of exclusion, meaning all other causes of gingival enlargement should ideally be ruled out first. The diagnosis is confirmed by interpreting clinical, lab and histologic data, and once this is achieved, treatment is aimed at restoring gingival anatomy using scalpel or laser excision, cryotherapy, or photodynamic treatment. Some lesions have been reported to undergo spontaneous remission, and recurrence is not uncommon. Meticulous scaling and root planing of teeth in the vicinity of the lesion should remove any irritant and facilitate the overall healing process, and to hopefully prevent recurrence down the line. Let me emphasize, however, that plaque control is not the primary treatment for this gingival pathology, because the lesion is not an outcome of a plaque-induced process. Our next case is this adult male, 45 years old, referred from his local dentist to our oral surgery department. The reason for his referral is because of a large intraoral swelling arising from the roof of his mouth. He was previously diagnosed with HIV infection some 10 years ago and had been taking antiretrovirals and diflucan. He states that the swelling has been present for the past 6 weeks and causing progressive left-sided facial swelling. He complains of having loosening of teeth, bleeding, and mild fever. He is an occasional alcohol drinker but denies smoking or using any recreational medicines. The last time he took in alcohol was 2 days ago. Extraoral exam disclosed an asthenic adult male with significant weight loss and emaciation. A diffuse hemifacial swelling of the left zygomatic region was noted without any skin alterations. The submandibular lymph nodes were enlarged ipsilaterally but were non-tender and freely mobile. Mouth opening, which was assessed by interincisal distance, was at least 4.5 centimeters. Intraoral exam revealed an ulcerated firm incisal mass measuring approximately 4 by 4 centimeters in the roof of his mouth, spanning anteroposteriorly from the 2.6 to just behind the 2.8 region. These teeth were at least Miller's grade 2 mobile, and deep furcation probings were recorded. OPG showed local bone resorptive features and several carious lesions with retained roots. CT scan revealed the mass to be a hypodense and destroying the maxilla, but there was no extension to the nasal cavity or floor of the orbit. An incisional biopsy of the mass revealed histopathological features of a diffuse sheet-like proliferation of rounded hyperchromatic cells looking like immature plasma cells and exhibiting marked atypia, high mitotic activity, and apoptosis. Large eccentric nuclei, prominent nucleoli, and abundant cytoplasm were all observed. These so-called plasmablasts were immunopositive for CD138, a plasma cell designator, but negative for CD20. Tingible body macrophages were also observed interspersed within the diffuse pattern, giving the histologic architecture a starry sky appearance. Further immunostaining revealed a marker of cellular proliferation, Ki67, to be highly expressed in the atypical plasmablastic cells. Additionally, in situ hybridization for Epstein-Barr viral encoded RNA was also strongly positive. Now, all the evidence so far are consistent with the diagnosis of Epstein-Barr positive plasmablastic lymphoma, an aggressive non-Hodgkin's large B-cell lymphoma which mostly presents in HIV-positive patients and has a propensity to occur in the oral cavity. In fact, it was first described in the mouth of HIV patients back in the day. It has a meal predilection and expands rather rapidly to infiltrate surrounding soft and hard tissues. It may be the presenting finding in an individual who unknowingly has AIDS and therefore, when diagnosed, could in turn lead to the diagnosis of this syndrome. There are a number of situations where previously undiagnosed AIDS patients developed this tumor, which then led to the reveal of the underlying HIV disease. About 3/4 of cases that occur in the setting of HIV are positive for Epstein-Barr virus. This virus takes advantage of the background immunosuppression and induces recurring genetic abnormalities in lymphoid cells. Some of these genetic alterations may be in the form of MYC transcription factor gene rearrangements, the most frequent being translocation to a location where the gene is constantly being amplified. Plasmablastic lymphomas can occur anywhere in the oral cavity, the gingiva, palate, tongue, and can mimic a number of other oral pathologies: oral squamous cell carcinoma, plasmacytoma, non-pigmented melanomas, Kaposi sarcoma, and other malignant lymphomas such as diffuse large B-cell lymphoma. Histology and immunohistochemical special stains are required for arriving at a definitive diagnosis. In support of the diagnosis, a triad to look out for will be Epstein-Barr viral positivity in the neoplastic plasmablasts, association with HIV, and a high Ki67 proliferation index. Let me emphasize, however, that a proportion of cases could be Epstein-Barr negative and occur in an HIV negative individual. Now, the treatment is a combination of surgery, chemotherapy, and radiotherapy and depends on the stage of the disease. The aggressive nature warrants aggressive surgical management involving complete resection and nodal dissections, the level which will again be decided by the stage of the disease. The chemotherapy regimen, which typically involves using cytotoxics such as cyclophosphamide, vincristine, doxorubicin, and methotrexate, is handled effectively by hemato-oncology. Of course, it goes without saying that the patient must be treated for his underlying retroviral infection and the more effective HAART administered. Overall, irrespective of which treatment is used, the prognosis for plasmablastic lymphomas, no matter which area of the oral cavity it occurs, is unfavorable and patients rarely survive past 12 months.